board-certified psychiatrist based here in Washington, D.C. I completed my medical education at the Jacobs School of Medicine and Biomedical Sciences at the University of Buffalo in Buffalo, New York. And just very recently finished both my general psychiatry residency and my Master of Public Health and Health Policy at George Washington University earlier this year. I am now working full-time as a psychiatrist at Whitman Walker in DC. And I'm going to be serving tonight as the moderator for the event. And really my goal is to, guide the conversation so that everyone listening gains a clearer understanding of local advocacy efforts in DC, as well as the really essential and important roles that both MSDC and WPS play in supporting and advancing these advocacy efforts. And with that being said, it is my privilege to introduce our guest this evening, Dr. Lacaille. Dr. Matthew Lacaille is the current president of the Medical Society of DC. He is a board certified in general pediatrics and pediatric emergency medicine, is a fellow of the American Academy of Pediatrics, and an active member of the AMA, the American Medical Association. He is an attending at local hospitals in their emergency room. He received his medical degree from the University of Massachusetts School of Medicine in Worcester, Massachusetts, and completed his residency in general pediatrics at McGaw Northwestern Lurie Children's Hospital of Chicago in Chicago, Illinois. And when he is not in the hospital or working with organized medicine, he enjoys running, traveling, and all things Disney. And I would like to pause for a moment to see if Dr. Lacaille has any opening remarks or comments prior to moving forward with the agenda for tonight's event.
I'm just really excited to be here, working alongside you guys in such a great legislative advocacy city. It's one of the big draws that brought me back here. I actually did my undergrad in Washington, D.C. as well, so I got bitten by the bug very early on in my career before I even knew I was going to go into medicine. And I've been back here since 2019, and I've dove right back into the legislative advocacy with organized medicine here at the Medical Society of DC and continued my work with the AMA. And it's been really fulfilling and a real cornerstone to my career, other than trips to Disney World. But
Thank you. And I would also like to introduce Dr. Hira Mohoidin, who will be serving as our Q&A facilitator towards the end of tonight's event. So feel free to put questions throughout the conversation in the chat, and we'll try our best to address all of them by the conclusion of the event tonight. All right, and if we could share the slides, that would be helpful. And before we dive in, I want to just take a moment to really outline the purpose of tonight's discussion. Advocacy is really such an essential part of what we do as physicians, especially in Washington, D.C. And it looks a little bit differently than advocacy efforts in other states. So understanding that landscape is essential for us as clinicians and leaders in organized medicine. And tonight we really want to clarify how WPS and MSDC do collaborate, share updates on ongoing medical advocacy in DC, review past and current efforts that are underway, and also identify emerging issues that will take place in the future and shape our work in the next few years. And I also want to be able to provide some more practical looks too at how the DC Council operates, because really understanding kind of how that process works is essential to having effective advocacy efforts. And with that goal in mind, let's begin by grounding ourselves in the organizations doing these works and better understanding how they work together. To really understand this, I think it would be really helpful, Dr. Lacaille, if you could talk about the overlap and the connection between WPS and MSDC.
Absolutely. So the Medical Society of Washington, D.C. represents all physicians in the district. You don't have to live here in the district. You can be licensed in the district and live in one of our surrounding communities. And I like to think of it as the water cooler for medicine. So we don't all get a break room, especially me in the emergency department. But, when you can get together with your colleagues around that water cooler and talk about all the issues that you're all facing, regardless of your specialty. So things that are unique to pediatrics, things that are unique to emergency medicine, things that are unique to psychiatry. That's why we have our specific organizations. But your medical society, your local medical society is here to really be that center of the Venn diagram and really be the place where things that are affecting everybody in medicine can be really talked about and elaborated on. And we can figure out the solutions that work best for everybody. Um, Nothing is easy. It all requires conversation. And again, I like to think of the medical society as that spot where we can really work together and expand our influence. As you guys may or may not know, we have our own advocacy committee within the Medical Society of DC, and WPS actually has a seat on that committee. And that committee is huge for us as an organization. That committee really directs what our advocacy efforts are. They make the policy recommendations to our board, and really affect change and act to enact a lot of the advocacy that we work with. So your guys' presence on that is so appreciated and so welcomed. And we're really excited to continue that collaboration for almost ever. As long as we're here and you're here, we'll always have a seat at each other's table.
Yeah, thank you for that. And I'm curious, like, what is the interplay also between like MSDC and on the more national level, the American Medical Association and maybe other national medical organizations? Like, is there interplay? Is there overlap between them?
Yeah, and so the Medical Society of DC, you hit it on the head right as we started, is that we are in the District of Columbia. So we are somewhere that functions sort of like a state, but we're not a state. The federal government is our backyard. And so we don't just see local legislation, we see a national legislation. So the Medical Society of DC is an independent group, and we don't require you to be a member of the American Medical Association, and it's not vice versa. But we work very heavily to not only influence the local legislation, but influence the American Medical Association as well to say, hey, these are the issues that we are facing here in the district, and we need your pull and your push to kind of move things forward for the rest of the country based on what we're facing here. So you may or may not know that the American Medical Association actually just had their interim meeting. Not far away in National Harbor. And so we were able to host them with our friends from Maryland and MedChi and welcome them into the district and really give them the insider's view of what's going on locally, how it affects DC residents, how it affects DC physicians, but also nationally about how policies that are made by our lawmakers are affecting patients on a more global scale. So we work really closely with them. We welcome their help on certain issues, and we know that they hear our voice on a lot of them.
Mhm. Yeah, so it sounds like there's a lot of like overlap between the two and a lot of collaboration then on certain issues.
Absolutely, there has to be, because the problems that we face in DC are not unique to Washington, DC when it comes to physicians, and
Mhm.
I'm sure we'll talk about those in a little bit. But the AMA depends on their state medical societies to really fuel the conversation. And we might be on the different coasts of Washington State, but there are issues in Washington State that affect physicians just like there are ones that are here. And the AMA can act as that water cooler where all the physicians across the country are kind of hanging out and saying, hey, these are the problems that I'm facing. How are they affecting you? How can we work together for a solution?
Hmm. Yeah, and I think definitely one thing that WPS and more broadly, psychiatry in general, and even physicians in general, one of the big issues right now that we're facing is scope of practice concerns. And I think we've seen, especially over the last, couple of years, repeated legislative attempts to expand prescriptive authority to non-physician clinicians. Just in Virginia, just our neighboring kind of state, we worked with the Virginia Psychiatric Society to combat some of the psychologist prescribing efforts that were going on there. So with that being said, I'm curious, like, what your thoughts are on, this particular issue, if MSDC has like taken a stance on this or had efforts for this in the past.
Oh, scope of practice is that like Hydra, right? The three-headed snake that just every time you cut off one head, three more grow back. And it's a constant battle. And I think that one of the things that really highlighted the issues surrounding scope of practice was the COVID-19 pandemic, where we were under a unique set of rules during that time, and there was a lot of leeway that started to kind of emerge at that point in the effort to preserve public health. And so, one of the things that we have seen since then is like specifically things like pharmacists being able to administer vaccines. And as a public health intervention, that's phenomenal because it actually grants vaccine access to more and more patients. You could get your COVID vaccine, now you can get your flu vaccine. But since the COVID pandemic, we've been seeing that a lot of patients will be going to pharmacies to get standard routine vaccines. And the real question is, where is that medical home going to be for that patient? And we see that now people are saying, oh, talk to your local pharmacist if you have questions about your cough and congestion, or talk to your local. So that this concept of scope of practice that started with really good intent has now morphed into loss of the physician in charge of the medical home for a lot of patients. And so, one of the things that's a really delicate balance is that when you're trying to manage access to healthcare in this country and locally, we want to make sure that patients do have access to great primary care, great psychiatric care, great emergency care. We want to make sure that the district is the premier place to get healthcare in this country. But we need to do it with keeping in mind that the physician needs to be the head of that healthcare team. And we will never lose sight that we are a team. I need pharmacists when I run a code because they're pulling up medications, and in kids, it's all weight-based dosing, and I can't do math that quickly in my head. But my pharmacy team really supports me. My PA team really supports me as well. While they're seeing lower acuity kids in the emergency department, while I'm actively running a code and I'm not worried about, those kids that don't necessarily need to see me immediately. And again, we are a team. We'll always work as a team. There is no I in team, but you always have to have a captain, and you always have to have, a way to direct things. And that always needs to land at the physician's feet. That's why we have the top of our license. And so, it scope of practice has been around forever. It feels like I remember hearing about it when I was a med student back in the day. Um, and now it's still there. We still fight for it. And it's again, keeping the patient at the focus and at the center of that conversation is the most important thing.
Mhm. Yeah, is that the like best advice you have for like physicians that are worried about scope of practice issues is to just keep the patient at the center of it then?
My best piece of advice is actually call your legislators
Mhm.
and always get involved. And I'm sure we'll highlight different ways to get involved at that point. But if you are a physician who's really worried about scope of practice, you really got to make those phone calls because people are making decisions about who can prescribe, who can give vaccines, who can make diagnoses, who can do these things. And they themselves are not physicians and they never went to medical school. They also never went to any sort of school to get any sort of medical training. And yet they're the ones that we're entrusting to make these decisions, which is why the physician is always so highly regarded by the legislative community. But we just need the voices there. Please call your legislature and really be focused on the fact that, hey, this is not about me and my ego. This is about what's best for the patient. And this is why this is what is best for the patient is the physician at the head of the healthcare team. And here's a specific example that I can tell you about one of my primary patients that something bad happened to or didn't have the best outcome that could have been prevented if the physician was in charge of the healthcare team. So those stories are important, and we are really focused on making sure that we are constantly in contact with the legislature and constantly letting them know that their constituents, our patients, are the number one priority.
Mhm. Yeah, that makes sense. Having those like personal anecdotes with their constituents definitely can drive home the message, I imagine.
Absolutely.
And something you mentioned before was telehealth, and that's definitely something in psychiatry that I think since COVID we relied a lot on, and meeting patients kind of where they are, like increasing access through telehealth capabilities. But I think recently there's been a lot of maybe things up in the air with telehealth, and if there's going to be new regulations, new kind of changes with that. So I'm curious right now what your take on that is in regards to like advocacy efforts for that. And especially like where do you see DC heading in terms of long-term kind of telemedicine policy?
I think that this is something that WPS and the MSDC really are hand in hand with because telehealth has really expanded the way that patients can access care. If you're in a rural area or you're in, say, Ward 7, Ward 8, and you don't have a car, but you need to have some sort of psychiatric help, and I don't know where your office is, but if it's in Ward 2 or if it's in Ward 3, how do you connect with those patients who really need your help, but might not have the ability to get to you? We are delivering health with care at that point, and we are really serving the community that really needs that benefit. So obviously, the medical society is very in favor of good legislation that could really codify telemedicine, making it really good for both the physician and the patient receiving the care. This is actually a really good example of where the medical society has a lot of influence at the national level within the American Medical Association. We are a small city state for all intents and purposes. Um, we are surrounded by very great neighbors, Northern Virginia, and Maryland. And yet, our patients who live in DC, some of them are vacationing in Delaware over the summers. Some might be going up to Cape Cod, which is right near where I grew up. But we need to be able to connect with them. We also have a bunch of colleges and universities here and thinkers from all over the country and all over the globe coming here to do amazing things, but they need healthcare. Um, the district then goes and talks to the AMA and says, hey guys, this is not just a DC specific issue. We are one good case study of how we have very fluid borders with our surrounding community. We really need you to take the lead because this is interstate, this is interdepartment, and you are the American Medical Association, and we depend on you to really drive it forward. Because a lot of the legislation is coming from a federal level. I do know that the American Medical Association has a whole resource for telemedicine, which I can put in the chat, um, because it's a very important thing that came from, yet again, the COVID-19 pandemic, right? We learned a lot about what we could do ethically and within our governing principles as physicians, and a lot of good can come from it. Um, I hope that helps.
Yeah, yeah. And I think, like with the scope of practice in mind, like telehealth is definitely one way to kind of also combat that and like increase access just naturally, like
Mhm.
you were talking about. And I think a lot of the time, these issues that we're talking about in regards to like advocacy come down to like the nickels and dimes, the dollars and cents. And I know in DC right now there's a real significant budget shortfall that definitely can have like major impacts on like healthcare, advocacy, all those things. I'm wondering what your take is on that though, and how you feel like that's going to impact like advocacy, what things may or may not be top priorities, things like that.
So advocacy is for the strong of heart. I will say because people say it's always a fight. I don't like to think of it that way. I like to be positive. It's always a great dialogue and conversation. And I often look at our role as a physician in the community as one that's really unique, right? We're all a little bit nerdy. We're all a little bit smart. We're all a little bit invested in education, and we're all really invested in science. And I think that those three things make the perfect advocate because we are the experts on our issues. bar none. We know medicine. We know medicine in and out. We know the practice of medicine. We know what goes into a patient interaction. We're all about education because our patients don't have a medical degree behind their name most of the time. Um, and we are teaching them about their condition. We are breaking down our high level science and really bringing it down to a patient first level. That's why we use patient first language. We don't use things like saying someone like, "Oh, you're tachypnic." Well, no, you're breathing a little bit fast. So that way we can translate it down and break it down. So we're educators at baseline, and we are lovers of science and what we do. And that means that we trust the scientific method and we really value facts. And I think our job in this element is to pursue advocacy with all of that in mind. Know that we are the best people to do this. We specifically know how gaps in Medicaid coverage and Medicare coverage will affect the patients of DC. We know it because we know the financial impact of it. We know how our practices will suffer. We know how patients will suffer and be shocked at a bill that comes in the mail, or have surprise billing or things along those lines. The budget shortfall in DC is dangerous. There's no real other word to use at that point because a lot of that pressure is going to be put on the Medicaid system within Washington, D.C. And even the Department of Health is aware of that. And so, as you guys know, there's a lot of public health intervention stuff that we can be doing in Washington, D.C. with a lot of really good, positive public health impact. But with the budget shortfall, and I'm sure you see it in your clinical environment as well, um, patients lack coverage. If we cut the funding, which we will, patients will lack the coverage, then they don't get care, and then bad outcomes happen. And we don't want that for the people of DC. And so I see it as our job to educate our legislatures and say, hey guys, this is really what's going to happen. And I'm not talking hypotheticals. I can give you a case example of one of my patients who this happened to, what that happened to, and this is the outcome that they suffered or experienced. Um, and we see it in all elements of our practice, whether you're in private practice, whether you're doing work at um, federal health qualifying health centers, whether you're academic. It's everywhere. And so I think that this budget shortfall is absolutely no joke. And I think the Bowser administration did a good job at trying to figure out the band-aids that we can get. But as you guys may or may not know, how the budget is done in DC, it's 4 years that it has to be balanced over, and then it's also approved by Congress. And so what we really need is a Congress that will really allow the district itself to invest in its own public health. So again, call your legislators, and really try to make that difference for the people of DC.
Yeah, yeah, that just goes to show again how like DC is a little bit differently than other kind of states, and that like the federal government has a lot of say in what does and doesn't happen. And I'm curious, along those kind of similar lines, another really important topic for psychiatry and I think physicians as a whole is the concept of downcoding and reimbursements and things of that nature. I'm curious if there's anything like emerging in the DC legislature surrounding this, or if there's anything that MSDC is doing to kind of address that.
So, yeah, I wish. The short answer is I wish. The long answer is that there was potential. I mean, there's still always potential. But there was rumors of a down coding sort of piece of legislation coming through that's been a little bit pushed to the back burner, not completely shelved. But we walk this delicate balance in medicine between progression of technology, which is amazing, things like AI, things like the health devices that really help our patients. Um, But AI has gone from being something that can help me with my documentation and my notes to something that's going to skim my note and then downcode it and be used against the physician from the insurance companies. And I am not making a moral statement on insurance companies because I am not a moralist or a moral theologian or a moral expert, but I know that what is bad for physicians is that if you are using technology against them, they're going to end up burning out. If you're going to use technology to say, actually, you didn't document this one social determinant of health, and it's too late for us to use the AI positively and say, hey, why don't you document this social determinant of health? When the insurance companies then come at it and say, like, well, you're just downcoded, as opposed to helping a physician be better or document better, that's a problem. The medical society is very on top of it. We know that we've got our friends on council who we can talk to and get their ear of, but the more that they hear from physicians across specialties, the better. And this is one of those water cooler conversations that we can have at the medical society because it affects psychiatry, it affects emergency medicine, it affects primary care. It's going to affect OBGYNs, it affects surgeons, it affects all of us. And we really need to be focused on saying, hey, AI is great. We really can depend on it in certain contexts. It really needs to be used to help the patient. If AI can prompt the physician to ask a question about someone's social determinants of health that can really have a positive impact on the patient care, we need it. But it shouldn't be used to penalize us on the back end. It should be used to say to a physician, hey, remind you, studies have shown that physicians talking about quitting smoking is a number one driver for patients to quit smoking. You need to address that in your next visit with this patient. That makes me a better doctor, and it also makes my patient a healthier person. And I think that that's the important piece that we need to be talking about when we start to do our advocacy around this topic. Because again, downcoding is bad. It's bad for patients, it's bad for clinicians, physicians, it's bad for practices. And again, it's not just bad for a private practice. It's bad for the academic tertiary care centers that we have in this city that really depend on Medicaid and insurance reimbursement to keep their doors open to really give that world-class care to all patients that come to the district specifically for their treatments. So it's a definite issue. The council is aware of it, but in legislative priorities, it's kind of getting shifted. But we're there at the table.
Yeah, yeah, it certainly sounds like MSDC has like a close connection with DC council members. Um, and I'm wondering, like, can you kind of talk us through like how the council actually kind of functions and operates? And if there's any like particular points in like the legislative process that, it's important to have physicians involved in?
Yeah, absolutely. So the district is obviously divided up into 8 wards, and each ward gets a council member. There are 4 at-large members of the council as well, and then there's the chair of the council. The chair is always elected by the entire district. Each ward elects their own council member, and we all elect the 4 at-large members. My practices are sort of throughout the district, but I live in Ward 2. So Councilwoman Pinto is my council person. She was, I think, just elected in 2025, so she's good for another couple of years. Um, but that's the way our council works. And so our council wants to hear from us. We are the people of Washington, D.C. We are the physicians of Washington, D.C. We are the healthcare professionals of Washington, D.C. We are really super valued when it comes to health related legislation. And they want to hear from how we think about certain issues. The majority of the healthcare legislation kind of comes through committee. So specifically for healthcare related things, obviously it goes to the Committee on Health, and that's chaired by Councilperson Christina Henderson. So Councilwoman Henderson really wants to hear from not just the Medical Society of DC. Well, we represent all physicians. She wants to hear from the pediatrician. She wants to hear from the psychiatrist. She wants to hear from the internal medicine folk, the surgeons, when it comes to healthcare related legislation. Um, because with our input, they can actually put forth the most impressive pieces of legislation and the ones that will have the best impact for patients. Perfect is the enemy of good. And we often say that, and we often hear that. But what we need to do is have the physician at the center and saying to Councilwoman Henderson and her team, like, this is why this legislation is great for patients. This is why this one is bad. This is what we could do to do things even better than we're already doing them. Um, those pieces of legislation go through committee, they go through the council, and then they're voted on. The majority of times, there's a public hearing on the legislation as well, so members of the public can come. I know that we usually get the Medical Society of the District of Columbia gets a little bit of a notice that's saying like, hey, this is a healthcare related topic that's going to be happening on this date at this time. If you have any representative that you could send to us and give us some background, that would be great. Sometimes that's me, sometimes that's members of the advocacy committee. Sometimes I'll be totally honest, I'm not an OBGYN, so I'm not an expert on OBGYN issues. So we go into our ranks and say, hey, membership, here's this public hearing. If you want to go to it, please let us know. We can give you talking points, we can prep you, we can help work with you on that, and get you and the medical society front and center with our elected leadership. So that's it's a really phenomenal opportunity.
Hmm. So it sounds like kind of at any point, like a physician can have like meaningful input in the legislative process then.
Oh, absolutely. And you got to remember that, we each get our own vote if you live in the district on this council for council members. But, you can also encourage your patients to vote. Um, Obviously, there's no partisanship in the exam room or in a clinic office, but helping a patient register to vote or helping a patient figure out what ward they live in. All this stuff is so easily accessible on DC's website, dc.gov, or even the DOH website to really help drive, voter registration and getting those voices to be heard. So again, your voice as a physician and as a physician advocate is so huge. I can't even say how much of an impact you can have to help patients really experience the whole breadth of our beautiful country. Um, and really for you as a physician to interact with the legislative process.
Hmm. Yeah, and I think, sometimes with advocacy and things of that nature, something I hear from like fellow physicians is like not even knowing where to start, like feeling very frustrated by these systemic things, but not really knowing like where and how to address them. And you definitely highlighted some of the ways that, physicians can get involved and engage with their elected officials. I'm curious if you have any other like recommendations for people that do feel that way about advocacy efforts, especially in DC.
Yeah, so DC is so wonderful because again, we have our local council, and that's a really all politics is local, is what they usually say. And so you can have a big influence on a large group of people. And, one of the reasons why I started doing advocacy work is that um, I felt like I can really advocate for a kid in a one-on-one interaction with them and their family in my ER, in my exam room. But when I constantly am having the same conversation with a family about how to get an inhaler to control your asthma, well, there's a systemic problem. And how can I fix that? And so, in that vein, I fell into my state medical society. Now, I've trained a little bit everywhere. I did med school in Massachusetts, did residency out in the Midwest in Illinois. I did fellowship back in Rhode Island, back in New England, and now I've been down here. So I've been like ping ponging all over the place. But the first thing I did anytime I finally got my address was join my state medical society because that is where I felt like I could really have that impact. And I won't lie, I grew up very modestly on Section 8 housing and on welfare as a kid. And I really relied on my state medical society to really bring me up and raise me and teach me and help me use my now very powerful voice to help the patients who are growing up just like I did. And that state medical society, it's no offense to the specialty society, because I did join my specialty society chapters in all of those states as well, because they have a very awesome place to help with advocacy efforts within my subspecialty and profession. But again, the first thing I did, joined my state medical society, figured out how to get involved with the legislative advocacy agenda, figure out how to work or bring up my pet projects to that organization so that I got a whole team of folks behind me to really build. And it's been really fulfilling. It's been really awesome to see my career evolve from medical school to training to now somehow becoming a grown-up in medicine. It's not, it's you know, you turn around and all of a sudden it happens.
Yeah, thank you for that. That definitely, I think, gives a lot of like practical kind of ways to get more involved and to engage with
Mhm.
um, politicians on these matters. And thank you for your remarks in general for tonight.
Yeah.
And with that being said, I want to get to some of the questions that I saw popping up in the chat. Dr. Mohiddin, would you be able to read off some of the questions?
Of course, of course. So the first one we have is from Dr. Dunlap, asking how common it is. She said pharmacists are sending COVID vaccination records to me, not to patients' PCPs. I've never requested these records and patients are not aware. Are others experiencing this? Dr. May said yes, but I'll also pause so you can answer.
So, as someone who works in emergency medicine, what I find hilarious is sometimes I get reports from subspecialists as well saying, like, your patient came in because patients don't know who their primary care doctor is. And so they'll just list someone down as saying, like, this is the person I usually see the most, and think that that's what primary means. And so again, it's really advocating for the patient and saying like, hey, do you have a primary care provider? Do you have a PCP? I am a subspecialist. Or when someone comes into my emergency department, like, I'm your doctor for today. I am not someone who you need to list on a bunch of different documents because I don't have any longitudinal care with you at all, hopefully in emergency medicine. Um, but I see it, which I find hilarious because all of a sudden I get this thing from a dentist that says, "Oh, your patient came in and had a cavity filled," and I was like, "Okay, thank you." And then it sort of gets lost in the emergency field because I don't have that longitudinal relationship with that patient, so I don't even know who to forward it to or even how to contact that patient. Um, it's weird. It's wild. I think Dr.
Dr.
Dunlop
Morgan, then
covered.
could I just address why I posted that?
Of course.
Yes, and I understand what you're describing, receiving records. When you were talking about pharmacists doing vaccinations, and this really emerged and took off during the pandemic, I started receiving records. And as Dr. May mentioned, I think the pharmacist is just choosing a doctor, and if I prescribed. And my point here is that you're talking about them providing clinical care, but there's no system set up for them to really monitor the care. And so they're just choosing a doctor. So this is minor on my list of things that I really am concerned about. I mean, let's be clear. I mean, we have bigger things. But I've even tried to call someone to ask, like, why are you sending this to me? And then I just said, okay, let me put that aside. But I think that's related to their gaining more clinical privileges and just managing it this way.
And I think that's the story that your legislator wants to hear too, as to what, like, I'm not this patient's primary care doc. but a pharmacist sees that maybe I'm the one who prescribes the majority of their medications, or that I'm the one who most recently refilled their medications. And then it opens up a whole can of worms of liability. Is that pharmacist saying that you're their supervising physician by like forwarding this like mail to you? I don't know the answer to that question, but it brings up more questions than it answers. And because of that, we need to say to our lawmakers, we need to cut this scope creep in the bud, because who's supervising them? Do you want a pharmacist running a code? Do you want a pharmacist like setting your bones in the emergency department? Do you want a pharmacist to monitor your response to an allergic reaction? What are you really gaining here? And I think that again, it was during COVID, special set of rules, special circumstances, but now we're back to normalcy, as best we can be. And so it's time to reevaluate all that stuff for sure.
Thank you so much for that question. Okay, the next one is from Dr. Schwartz. Any advice for how we build connections to become resources to our council members, especially in this very complicated time for the DC Council? Our wonderful moderator, Mark, has been trying to connect but has run into some roadblocks.
I don't want to speak for Mark and his experience. I will say join the medical society. And that's not a shameless plug. Um, we have Meet the Council days, and the medical society and the council are so invested in those days. And it's not even Meet the Council with a specific legislative agenda topic that we try to do. It's no, just come to the medical society, bring the physicians, bring the membership, meet the council. Just meet them. They want to hear from us. Meet them, meet their legislative assistants, meet their advocacy related teams, meet the folks that you can interface with one on one. Healthcare legislation in the district is at a really weird time because, as you guys know, we are a pseudo independent, but our Congress really has a lot of sway over our city. And given the tightrope that we're walking between science and medicine and advocacy and public opinion, Dr. Google, Dr. WebMD, um, things have become a little bit more vanilla than straightforward and a lot more nuanced in order to get things sort of through. So I'm interested to hear what the issues have been and to see where we can all interface and interlap and hopefully break down those barriers.
Yeah, I think the biggest issue is just kind of getting started and knowing like if you proactively should be reaching out, if it's like more reactionary, like when an issue comes up or things of that nature. And kind of like the initial steps, I think are the most challenging right now.
So I would say it's both. If you are noticing a problem that's coming up over and over and over again, go back to WPS, come to the Medical Society of DC, um, kind of say, hey, this is a problem that I'm seeing over and over and over again, kind of like what Dr. Dunlap did earlier tonight. Like, hey, I'm seeing more and more uh, vaccine records sent to me for some unknown reason, and say, hey, is this an issue that we are noticing more? I will say that your medical society is both specialty and state or district. Their staff is really well plugged in, and they can really say, like, you know what, let me ask my colleagues in a different state, or let me ask my counterpart at the medical society. Let me ask so and so and see where their membership is experiencing something, if they're experiencing something similar. And then you coalition build. And then once you can coalition build, you can go to your state legislator or district and say, hey, myself and this group of physicians, here are their names, here's their contact information, these are the wards that they live in. They're really experiencing this issue that we need to talk about. Can we set up a meeting to talk about it? 9 times out of 10, you'll get a legislative assistant who's going to meet with you and talk with you, which is why the Meet the Council Day is so great because the council members come. Um, but use that opportunity, use that leverage. And I think that it's opening up, that goal is to open up a dialogue because then they'll be like, oh, I know this psychiatrist who practices at Women Walker who really wants to get involved in this. And I just talked to him the other day about a different topic. I wonder what he thinks about this other thing that just popped up. But I know he's a physician, so he'll have a great opinion and a trusted opinion. So, like, let me contact him. So, the more you actually do that dialogue, the closer you'll get with that council member team, and then the council member themselves. And so that is how I would say, like, is it reactionary sometimes? Is it like preventative? Also sometimes. Um, and it's dialogue and it's relationship building. And then it's all of a sudden you're the trusted person that the healthcare legislative assistant is going to direct the question to.
Yeah, it sounds like that relationship is really essential then. Thank you for that.
Thank you both. I've noticed the same now working as the healthcare legislative assistant and seeing it from the other side. And it's absolutely true that we remember who we've spoken with, and I've circled back actually when something's been passed or I've been able to get the boss to sign on to an initiative. I'll circle back, and so we continue to stay in touch with those who reach out to the office. Um, Dr. May was also kind enough to say that Council Member Fruman in Ward 3 should be open to hearing from psychiatrists, as he attended a benefit in November, was very interested in serving underserved populations. And then she asked a question. How can contacting the insurance commissioner be of help in improving access to care? I have on occasion encouraged patients to write their insurance company and copy the insurance commissioner when they're running into brick walls.
You know, it's hard, again, insurance. Ugh. Um, I withhold any moral judgments on insurance companies. But sometimes they want to hear from us, sometimes they really don't. But regulation on insurance companies is something that they care about a lot. So again, talking to your council team about insurance providers in the district is probably very eye-opening to them because I'm sure that they have very minimal interaction with that system at, on the level that we do. And explaining to them the issue that you're running into beyond prior authorizations, random, all of a sudden, seemingly new prior authorizations for medications that the patient's been on for years. Um, I don't do prior authorization. I just say the other end of it, where prior authorization has become a problem. So I can't get this medication. So now I need to go to the ER because either I'm having psychotic break, or I'm having chest pain and an MI, or I'm having these things. And so again, the insurance commissioner is a good resource. When I said advocacy is not for the faint of heart, it's for the strong of heart. That's part of the reason why. It's because sometimes you run into the brick wall, and sometimes because politics is personal, and politics is people. Sometimes it's a long game in order to kind of go around the wall or go over the wall.
Thank you. And Dr. Dunlap, shared a very helpful comment that yes, voting is officially recognized as a social determinant of health by major medical and public health organizations, including the AMA, the American Public Health Association, and the U.S. Department of Health and Human Services through its Healthy People 2030 initiative. So thank you for sharing that. And then Dr. Schwartz asked, since DC is a district and has a council, could you talk about how this works similarly or differently than typical state legislatures?
So it works similarly and differently, right? So the similar things are, as opposed to counties, we have wards, wards 1 through 8. I can give you the example of Massachusetts because I grew up in Massachusetts and I was in Bristol County and we had our county representatives and um, uh, that's how they sort of made our representation in the legislature. Um, the council is a little bit different because we don't necessarily have like a two chamber of government than other states do. Um, and we don't have a governor, obviously. We have a mayor. So it's a lot of more of a microcosm scale, um, which is both good and bad. I honestly see it as good because you have less people to convince of the importance of the work that we're doing and the importance of the topics that we're advocating on. Um, but at the same time, it takes only a couple folks to sort of derail or shelve or reshuffle the legislative priorities for the time being. So I will say that we are so unique and lucky to live and work in the District of Columbia. I do both. I know not everybody does both, but I live and work here. Um, and I consider myself really lucky that I can lean on our EVP and say, "Hey, Robert, I really think that we need to get in touch with Councilwoman Pinto or Henderson on this topic." I'm happy to talk to Councilwoman Pinto from my perspective as a member of Ward 2, like a citizen of resident of Ward 2. But I'm also really happy to talk to Councilwoman Henderson as the president of the Medical Society of DC. So what do you think? And it's, again, because it is a micro sort of cosm of politics, it's a lot easier to get things done, but that also comes with that other edge of the sword of, yeah, but it takes only one or two folks to sort of shelve something or put things on a back burner. I'm always optimistic that they'll come back into the front burner, but I'm not a chef either.
Thank you so much for that. So Dr. Dunlap says that she may have missed this at the beginning, so I apologize if you addressed it. What is the WPS's working agreement with MSDC in terms of advocacy, if we have one? By the way, I'm an MSDC member and support its mission.
I love that. Thank you so much. So the way that we do a lot of our advocacy, we talked a little bit about at the beginning of the hour, is just we have an advocacy committee within the Medical Society of DC, and on that committee, WPS has a seat. So we don't make decisions in isolation as the Medical Society of DC, saying this is what we think is the most important thing. We lean on our membership. But specifically, WPS has a seat on the advocacy committee, which is currently co-chaired by Dr. Sarah Candler, who does internal medicine and geriatrics, and Dr. Clint Peoples, who is also the president-elect now of the Medical Society. So you guys will meet him in a year. Don't get rid of me too quickly. Literally, it's my term just started, so you're stuck with me for a year. But Dr. Peoples and I have actually known each other since medical school, and he's a phenomenal advocate. He's taught me everything I know about legislation and how things work, so he's going to be an even better president than I am. Or hope to be. But he will continue that mission and continue that work. And I don't see that partnership going away anytime soon because there are no better advocates than people who really work with the populations that really truly suffer and are the most vulnerable. And I know we're not supposed to talk about like vulnerability first. That's not the point here. The point is more that psychiatry teams, I personally believe pediatrics teams, we take care of people who cannot advocate for themselves. And because we do that, we are natural leaders in this space and we depend on each other to really make forward progress for our patients and the people who really need it most. So I just want to say thank you to WPS for being this partner with us for as long as you have been. And I see it going far into the future. And that seat is not going anywhere. And as medical society members, you guys are also more than welcome to attend those meetings and help drive that agenda and drive that advocacy team. So yeah, it's a great relationship.
And Dr. Dunlap thanks Dr. Rushai for his leadership in this space.
Thank you. Well, this was a really great conversation. I appreciate you taking the time and talking about a lot of these really important issues with us. Before we conclude, is there any like final remarks that you have? Anything else that you feel like we should know for this evening?
Get your flu shots because the flu is back and it's raging. Make sure your patients do too, if they can. Um, I will say that it's always a pleasure to kind of sit at a table with other like strong advocacy teams, and it's such a passion of mine. I hope that came across. And I can't wait to work with you guys over my presidency and my immediate past year as well, because we are definitely in need of some strong advocates right now. Especially with the current legislative climate. And it's not for the weak of heart. We're in this together, and as long as we're holding hands and doing it together, we can really accomplish a lot despite any challenges.
Well, thank you very much for joining us this evening. And yes, this is a great slide to conclude on. These are some ways that everyone can get more involved in advocacy and things of that nature.
We
Oh yeah,
do
do
not yet
we?
have a date for the next Meet the Council Day, but it's usually in the spring. So our EVP, Robert Hay, will be able to kind of get that information out to your team.
Hopefully we
Excuse
can
me.
all be there.